may begin.
Thank you. Good afternoon, everyone, and welcome to The Learning Curve, a Geriatrics professional development series. My name is Lauren Jones, and I'm the Geriatric Scholars Program Manager at the GRECC here in Los Angeles. This is the first in a three-part series. The topic today is peer-to-peer education, and our speaker will be Dr. Helen Fernandez. Before Dr. Fernandez begins her presentation, I have just a few notes. This series is sponsored by the Employee Education System, EES, in collaboration with the Consortium of New York Geriatric Education Centers, the Arkansas Geriatric Education Center, and the Geriatric Scholars Program, which is funded by the VA Office of Rural Health. This presentation will last 45 minutes with a Q&A session of approximately 15 minutes. During this session, please type in your questions under the Q&A tab on Live Meeting, and the presenter will verbally answer your questions in the order in which they were received at the end of the session. If necessary, you can raise your hand by using the Q&A tab. The hand icon is located on the far right-hand side. This session will end promptly at 3 p.m. Eastern. If you have any further questions for the presenter, please send them to me at lauren.jones@va.gov, and I will forward them to the speaker. For your convenience, you are pre-registered for these meetings. To receive CME, CEU, and to complete your registration, you must contact your Vision Satellite Coordinator using the list I emailed you and request the registration and evaluation form for the course. If you have any questions about the process, please refer to that email that we sent you with the EES contact. Now, I would like to introduce our speaker for today. Dr. Helen Fernandez is an associate at St. Vincent's Medical Center in New York City. She completed a fellowship in geriatrics and served as a fellow at Mount Sinai. She also holds a Master's of Public Health degree. In 2002, she received a Geriatric Academic Career Award. Her career interests include osteoporosis, evidence-based medicine, cultural competency, and medical education. Some of you all may recognize Dr. Fernandez from the New York Intensive and Board Review, as she was one of the course directors. She is also course director for the Master Clinician Educator Program in Geriatrics and for the Geriatrics for Non-Geriatricians Physician Mini Fellowship Program, funded by the Donald W. Reynolds Foundation. She is principal investigator of an Aetna Foundation grant to teach medical students about the interaction of culture and palliative care. In 2006, she received a grant from the Aetna Foundation for a project on the impact of culture on palliative care education. In 2007, she became the co-program director of the Consortium of New York Geriatric Education Centers. In 2008 and 2009, she has become an active member of Ethno-Geriatrics Committee of AGS and the Health Disparities Task Force for SGIM. With that said, it is my pleasure to welcome Dr. Helen Fernandez. Dr. Fernandez?
Thank you, Lauren, for that wonderful introduction. I really am excited to join all of you today and hope we have a great opportunity to have a discussion about how important peer-to-peer education is. So I wanted to start off with
Someone has entered the conference.
Some objectives that I hope to cover in these 45 minutes. So at the end of this session, I hope you as participants will be able to discuss the impact of peer-to-peer education, define communication skills, define knowledge transfer, be able to name 3 characteristics of effective communication to improve this knowledge transfer, and discuss barriers to effective communication. So I wanted to start off with a case. Margaret is a second-year family medicine resident. And during a case conference, she is presenting a follow-up case who was discharged from the hospital to your team. And the team consists of who are in the room, in the conference room. She has an attending physician, a family medicine physician, as well as a nurse practitioner, a social worker, as well as a nurse and a medical assistant. As she presents, she tells us this is a 74-year-old woman who came today to the clinic. She has a history of atrial fibrillation and hypertension. She was discharged from the hospital 2 weeks ago, but I am unsure what they did. She was discharged on an antibiotic and her usual dose of Coumadin. No one has checked her anticoagulation, the INR level, in 2 weeks. So I have kind of on the next slide some questions to consider when hearing this case being presented. And one of the questions I want to raise is what would we be most concerned about in the care of this patient who's transitioning from an inpatient setting to an outpatient setting? So in thinking about these transitions, as many of you have experienced, there's usually, and not unfortunately so uncommon, of not really having all the information.
Someone has entered the conference.
This information with the transfer. Many times what actually happens in the hospital, we don't get all the test results. We don't have, at times, patients' medications are being changed, or there are new medications that are being added that we are not given adequate information. It's confusing for the patient as well in terms of knowing what should they do with the medications that they have at home. Are they on a new regimen? Do they discontinue the old regimen? Or do they just add the new medications? Did she have adequate support on her discharge? Did she need more help? So some of these things are things to consider with these transitions of care. And one of the biggest ones is when a new medication is added, when there's an other medication like the Coumadin or warfarin that can interact with her new medication, the antibiotic. And what medical errors can happen if you, as the healthcare team that is taking care of her in an outpatient setting, do not have that information. She's at risk, obviously, with this new antibiotic and this other, maybe her anticoagulation being out of control and being too high and a risk of bleeding. So how can we prevent these medical errors from happening? How can we improve this knowledge transfer so it's a safe transition of care? And I'll talk about different scenarios and where this occurs in terms of how we can improve this knowledge transfer to be able to improve better health care and patient and quality of care and safety. So, with Margaret, the resident, what kind of feedback can we give to her? Where can, we can ask Margaret, where can you get this information?
Someone has entered the conference.
How can you fill in the gaps? This is a great opportunity to call the team that took care of her in the hospital, to ask to have a discharge summary faxed over. So Margaret can learn that there are ways to improve for dialogue between the team that was taking care of her patient in the inpatient setting and now with her. So some considerations to help Margaret more effectively take care of her patient. So with that in mind, let's talk about what happens when communication does not occur effectively. And this is really kind of in the realm of the quality of care, the report that was developed by the Institute of Medicine in the year 2000, to err is human, and reported the number of deaths associated that occurred annually related to medical errors, which were from 44,000 to 98,000. And the cost of such errors were in the billions, from 17 to $29 billion. Astounding in terms of what happens when these medical errors occur. So why do these errors occur? Well, several reasons. One, fatigue, interruption. We're doing too many things at the same time. We're multitasking. We're great at that. But sometimes it means that we're not paying attention to every detail. Failure to follow up, poor handoffs, ineffective communication, which we're going to really be emphasizing today. There's a hidden agenda. There could be a hidden agenda, not following protocol, being sometimes too courteous and not asking questions. Or might be some complacency. Or, you know what, that's not part of my job or my area. So these are many reasons why errors can occur. So really the errors, medical errors, are really the leading cause of this patient safety issue. More Americans die from medical errors than they do from breast cancer, AIDS, or car accidents. So largely very, very impactful. And here, probably for some of you, is a reminder of how hazardous healthcare can be. As we can see to the left, the very dangerous events, and as we go to the right, ultra-safe events, and really being able to fly in a scheduled airline or using nuclear power or using the European railroad is really ultra-safe with less than 1 in 100,000 deaths, as compared to healthcare, which is really at the top of the dangerous arena. So we can see how patient safety is very much an unsafe world, and how the components of communication really affect the safety. So what has happened with this movement of improving patient safety? Well, in 1995 was really where we started getting a general idea and more media attention of medical errors in national hospitals. And as I said, 99, 2000 is when the landmark report came out to err is human. And then in 2001 is when the Joint Commission established a national patient safety and required hospitals to notify patients if harmed by a medical error. In 2005, we had the Patient Safety Act, which encouraged voluntary and confidential reporting of events. 2006, the American Board of Internal Medicine included patient safety on certification exams. In 2007, we had the National Quality Forum establishing guidelines for disclosure. So you can see how we've developed in terms of a response to that original report and a media report that occurred in 95 and 99. So how can we improve as healthcare providers? Well, one of the biggest areas where patient safety issues lie are in the arena of communication. And really, I mean, we have conversations every day with our peers in terms of handoffs and transitions of care. So what are communication skills? It's a discrete mode by which a healthcare professional can further the clinical dialogue and thus achieve a strategy. And really, this is part of professionalism, right? Professionalism has many components. It has communication, knowledge, technical skills, clinical reasoning, emotion, values, and being able to reflect in daily practice for the benefit of the individual and the community being served. So really it is part of our professional duty to improve our communication with our patients, but even more so with our peers as we are taking care of patients in different settings. So as we see here in this slide, you can see really the building blocks of professionalism. Being able to be clinically competent, being able to communicate, and having an ethical and legal understanding, as well as providing excellent care, being humanistic, accountable, and altruistic. There are many things, and it's a high standard of which we are to deliver and be professional. And communication skills, as you can see, is really the building blocks of our profession. So how does effective communication, when it does happen correctly, impact healthcare? Well, it can improve many different arenas. It can help in terms of diagnosing more effectively. It can help in clinical outcomes. it can help your patient feel more comfortable, right? You become more satisfied in being able to deliver care, right? And your patient becomes more satisfied. Your relationship with your team improves as well. And therefore, if the relationship in the team improves, therefore the work that the team does and the impact that the team performs will improve as well. And obviously, it'll also help to diminish medical errors and increase patient safety. So we can see that the data has shown that the more effective we communicate, the better these areas will actually be. So better communication really equals increased knowledge transfer. So what is knowledge transfer? It is an effective method to introduce and implement more effective patient care based on evidence-based medicine. Right? So really knowledge transfer had occurred in the arena of being able to translate research that is happening into actual patient practice. And several organizations like ARC have been using different models to try, how do you really get research that's being done out there translated much sooner and not delayed in terms of actually being implemented in patient care? How can we improve it so that it doesn't take 5 to 10 years to have a guideline that people follow? Right? And communication is really the basis of that, is being able to tell people, you know what, this research exists, it's improved health outcomes, and it's time to use it. So in thinking about ways that we can improve our communication, we've talked about kind of the definition of communication, what's the impact of communication, how it interacts with knowledge transfer. Now let's talk about ways to improve communication. So the standards of communication can be improved by thinking about different categories. One, you want complete information. So you want to include all the important information. You want to be clear, so you want to be able to express plain language that's well understood. You want to be concise as well, and timely. What are other basic skills that are part of those general frameworks that can help you become more effective communicators? Listening. Often we interrupt people as they're presenting and trying to tell you a story about your patient. Take a moment, take some time, and listen to what is being said. Asking open-ended questions, but also you have to balance them out with closed-ended questions as well. Paraphrasing, summarizing. Is this what I heard? Using facilitators. Sometimes within the team, you need help in terms of improving your communication skills and need someone to help facilitate that conversation. They're often nonverbals. Somebody is closing their eyes, falling asleep, not paying attention, kind of really pick up on those clues. Is something happening? Why is that happening? Are they just tired? Or is my message not getting across? And then taking a moment of silence and seeing how that information is being absorbed. So here are some methods. We're going to talk about a couple of different methods to improve communication with your peers so that you can increase knowledge transfer. One method is a situation background assessment recommendation. The other is the teach back or check back. And I'll talk a little bit more about that because that's not only is important with your peers but also with your patients, and handoff. And really a lot of these techniques are not exactly new but have been packaged newly together by ARC, which is the Agency on Healthcare and Quality. And they developed a new strategy called Strategies and Tools to Enhance Performance and Patient Safety, called Team Steps. And you can actually go to their website, and they have different training modules that you can go through that help you with some of these steps and videos as well. So let's talk about the first method, the situation background. So communicate first the situation. What's happening with the patient? Tell me the story. Background. Is there any important clinical information that I should know? What is this patient's past medical history? What's the patient's past surgical history? Assessment. What do you think is going on? Right? Problem identification is really what you're getting to in terms of assessment. Recommendation. What would I do or recommend? So this is a framework to help you more effectively communicate. Let's talk about another method, the teach back or check back, which you can use in combination with the first one. The sender initiates the message, the receiver accepts the message and provides feedback. But you as a sender, as somebody who's giving the message, want to check that it's actually being understood. So you can ask a couple of questions. Can you explain what I just said? Can you summarize it? Can you paraphrase it? Tell me 3 things I just told you. And then always give an opportunity for questions. So this is verifying that the information that you're delivering, your peer is actually understanding, and that you don't have to make some clarification when you're giving this information. Handoff. So this is kind of in the arena where we started off before in the case scenario, where there was this transition of care and being able to effectively communicate from one arena to the other, or within the same arena from one time frame or one shift to the other. So this is a transfer of information during transition to care across the continuum to include an opportunity to ask questions, clarity, and confirm. And this is one of the biggest areas where there is a fault in terms of communication, where there are biggest opportunities to have errors when you're doing these handoffs. So how can you make it more effective? So one mnemonic that can help you in terms of being able to be more effective in handoffs is I pass the baton. And again, it's not so much that you remember everything of what the mnemonic says. Some people, mnemonic help, and for some others it doesn't. But it's just a way, again, a framework to consider how to give this handoff more effectively. So the I being introduction, introduce yourself. How are you caring for this patient? Patient identifiers, age, assessment. What is the case? What do you think is the situation? What's the current status? What treatments are the patient receiving? Are there any recent changes that I should know as somebody receiving this information? Safety, any critical information such as allergies or alerts or lab values that I should know about. Because it might be important, especially when I'm taking care of this patient, that I know they're allergic to penicillin, or that they're more anemic. Some examples of something that you would want to know as somebody who's taking over the case. Background, previous medical history, medications, actions, what actions are taken or are required and why. So a lot of it's prepping your colleague so that they, who don't know the patient as well, are able to get a better idea of who the patient is. Level of urgency, timing, ownership. Who else is helping take care of this patient? Who else is responsible? Next, what will happen next? What is the plan? And that really helps with somebody who's just taking over the case, who may not know all the full details. This will help them know, okay, the patient's being prepared for a discharge tomorrow. What are things that I need to do tonight to make sure that that goes as smoothly as possible? Or a patient is being prepared for a test that they're gonna have that evening, And so you're made aware of this before you start taking care of the patient versus you're given a phone call and all of a sudden, oh, they're going for this test you didn't even know that they were going for. So it's to help better improve that care of that patient as well. So what other ways can you improve peer-to-peer communication? You have to learn that you have to be flexible. So we're not always right, and sometimes we need our opinions of our peers to help us adjust a little bit. You want to avoid distractions. Be honest. You know, if you're having difficulty with your peer, but you want to do it with care. You have to be comfortable with areas that you may not have all the answers to. So those gray areas. You want to have integrity and build trust in terms of improving that peer-to-peer communication. I want you to think about reflect on your peers in your group. Think about what you've learned from your peers. What has been positive and what has been negative? How have they affected your life? So many times, as you think about some positive thoughts, you know, in terms of your peers, you may learn new knowledge that you didn't know before. They may have experiences that you've never had before, and they'll help you through a new experience. Right? So some examples of some positive outcomes from peers. There's also negative ones. Sometimes we don't have the greatest relationship with our peers. How do we examine and reflect on that? What happened in that relationship that made it negative? Was it misinformation, miscommunication? What was it that didn't make it as effective? So as you think about and reflect about what have you learned from your peers, I think you can start thinking about how can I, you know, as somebody who might have not had the greatest experience, how can I become a more effective peer educator? So what are some benefits of peer-to-peer education? And a lot of this peer-to-peer education comes from the Association of Medical Education in Europe, and they've published several articles in Medical Teacher around peer-to-peer education. And there's some areas that are really important that are beneficial. One, enhance intrinsic motivation. Your peer can help you become internally motivated because you want to be able to sometimes mimic the roles that they've taken. They've taught you some new skills as well. It helps in terms of socialization and provide role models. So many times it just doesn't have to be a senior role model. It could be somebody that is your peer that could be a role model. Peer education helps in teaching pressures as well. We're seeing more and more. I do this within my fellowship where I have the fellows teach each other and then teach their near peers as well. Just because you don't have to wait until somebody becomes higher in the hierarchy to start teaching. So, and sometimes it's not even so concrete, like this is a teaching session. It may be something that's just happening at the bedside or happening in a meeting. But it helps and actually creates better buy-in when you have another peer because they understand kind of what you're struggling with in terms of learning new information. So they create this more comfortable and safe educational environment, right? I mean, it gives you an opportunity to say, you know what, I can mess up a little bit. You know, I don't have kind of this senior person watching over me, critically evaluating me and giving me a grade. you can be a bit more comfortable and then allow an opportunity to get feedback and corrective action probably more easily than sometimes we do in a hierarchical relationship. It starts creating a level of confidence, and it helps in terms of developing leaders as well. So as you can see, there are many components in terms of the benefit of having peer-to-peer education. You want to create in this arena, right, many times peers are the ones who know best in terms of competency. They're able to evaluate how competent someone is because they're the ones who see them day to day doing what they're doing, and sometimes somebody who's a supervisor may only see them in certain times when they're available to evaluate the learner. So this creates, peer-to-peer education really creates a great forum in terms of, and we've been doing it, unofficially or not so well described, but now we're realizing that we need to embrace it. We need to realize that so much of it is happening every day in front of us. And there are courses that are now looking at mechanisms of having peer mentoring, so not only teaching, but how can I mentor somebody? I think about myself when the process of going through a promotion and how much kind of my experiences people now come to in terms of when they're going to be promoted. How did you do it? What were the steps that you took? How can you help me do it better? Because sometimes they're fearful about asking their supervisor because they feel like, you know what, you should have known how to do this, the unspoken rules. But with a peer, you're more comfortable in asking those questions that you might feel are too dumb to ask. So how does working, with this peer-to-peer education and improving knowledge transfer, how does it affect healthcare? Well, it definitely improves quality and lower cost. It decreases length of stay. It reduces medical errors. It can improve outcomes from many of the chronic diseases such as diabetes, CHF, hypertension. So the more effective we are in terms of conducting peer-to-peer education, the better we are in terms of improving healthcare. So what are some future steps for increasing this knowledge transfer? Well, example like this webinar, workshops, webcasts, training programs, workbooks, providing people with leadership opportunities, being able to publish more about peer-to-peer education. And I think this is an opportunity as we see kind of more and more the impact of peer-to-peer education to really see that there's a large rationale in terms of utilizing. There's a dimension of psychology, of why this is so important, of the ability to improve socialization, to create more goal-oriented information that's processed in a way that another peer can understand. Because sometimes when you're so far away from the knowledge attainment, you may not completely understand how the peers are able to process new information. So having someone as your peer re-explain something, and that's something that you just heard and don't quite understand, a way that's more understandable to you makes it increasing that knowledge transfer. So we've gone through, really through several points today. We've gone through the point of the impact of improving communication, defining knowledge transfer. How is this impacting the quality of care? How can we make it more effective in terms of improving our communication, so thus improving our knowledge transfer? What is the impact of peer-to-peer education? And finally, what are some of the future steps that are happening out there that are going to help us to improve this knowledge transfer? So I'd like to open this up to having some questions and a discussion of this very thought-provoking area.
Yes, thank you very much, Dr. Fernandez. Like Dr. Fernandez said, we now have some time to take questions either through the Q&A section on live meeting written, or I believe also, Dr. Fernandez, if it would be okay if someone had a question over the phone.
Yes.
Open it up for questions, please.
So what are some people's experiences with peer-to-peer education? What have you learned from your peers? Let me pose that as a question out there.
Hi, Helen. This is Judy Howe. How are you?
Hi.
Well, I mean, I think I liked your example of, turning to a peer for advice in the promotion process. And I personally found that, a peer, a trusted peer, colleague is a little safer place to be when you want to bounce ideas off than maybe somebody further up the, in the departmental hierarchy, as you mentioned. I wondered, have you, in terms of peer education and peer support, have you had any experience with peer-based brainstorm groups, research groups, groups that work together to publish?
Yes, we had in our institution for about over 2 years a monthly peer mentoring group that not only worked on the aspect of self-promotion and career development, but also as a larger group thinking about what could be a new research project we can collaborate together on, what could be some ideas of workshops, of presentations that we have common interests in, and that we have some talent and information we can share. These groups can really actually increase your productivity because you're working together, and so often we're in our silos, and just working on what we're working in our niche, and don't realize that there are other people that could have similar interests that you can tweak and develop projects together that could then be an actual grant, a project, a publication. So that was an outstanding. We had a group of about 10 to 12 people, a commitment to each other of a monthly meeting, no matter what happened, and some assignments of tasks of what's our common interests, where should we try to put our efforts in terms of new projects that we would like to work on.
So that's an excellent example, and I myself was involved in such an institution-based group similar to what you described. I also would just like to add that I think having peers from other professions and disciplines is often very energizing in terms of thinking about interdisciplinary research collaborations, writing collaborations, clinical QI collaborations, and so that would be another peer-to-peer mentoring opportunity that I would encourage to be interprofessional.
Right. Often the great example, Judy, in the quality improvement world, it isn't just one discipline. right? There are many disciplines that are part of the quality improvement project, and you could have a group that's all one discipline, and they want to have this other group do this specific task, and that's not going to work unless you have the other disciplines helping you brainstorm and working together to have a project that actually works. So kind of having that diversity within the peer collaboration group will only increase, as you say, your ideas, but also the success of the outcomes of your project.
Right, because you have the stakeholder involvement.
Right.
This is Nina Tomosa in St. Louis. Thank you, Helen, for that presentation. I learned a lot and was reminded of a lot of things which made sense now. I think that you made a statement just a minute ago that bears repeating, and that is that if you work with peer-to-peer, you should have a regularly scheduled meeting set. It's sort of like, yes, I'm going to go to the gym and exercise, but unless you put it in your calendar, it doesn't happen.
You're quite correct. I think that definitely is one of the biggest obstacles, because we come up with many excuses. I'm too tired, it's too late, but having a commitment, having a set time, having a set date really helps in terms of fulfilling it. You're right, it's like going to the gym or being on a diet. It's kind of this behavioral change that we have to do in order, and once you do it and you get into and you see the benefits of it, the more you'll want to come. It's not just an obligation, and it's not something like, oh, we had a name and don't actually do. And I think another thing that is also important is rotating the leadership within the team, within that collaborative group. So everyone has an opportunity to develop leadership skills in running a group like that.
Right.
Some other thoughts, some other experiences maybe with a peer group. And it could be any examples. It could be examples where it's more of a clinical team that you might have been part of, and sharing some of those experiences. It could be more of a mentoring or leadership group. Anybody else out there who could share with us some of their experiences?
I'm curious. This is Judy Howe from the Bronx GRECC. Are there any rural scholars on the call who, engaged in more peer-to-peer learning as a result of this program when you've gotten back and worked on your projects?
Yeah, Dr. Pavluri.
Hi.
Hi, how are y'all doing?
Good. So tell us about kind of how, through this program, what group as a peer that you were involved with?
Actually, I'm still working on the dual care model. To improving the communication between the private providers and the VA providers, so that there'll be less pitfalls. For the continuation of care.
Mm-hmm.
It's kind of, peer-to-peer. And sometimes it's hard to get in touch with since then, actually, I tried to even before then, I was doing, the contacting the private physicians outside. Actually, we got a couple of them, taking care without getting into the pitfalls. So a couple of patients were taken care of very effectively in a timely manner.
So what do you think made it more effective? Like what happened?
See, basically, I think I do not know whether we have sometimes. In the private sector, if the time constraint is the factor, it's not just the physician itself, but sometimes the timeliness, and the patient was told already that his PSA was elevated and that kind of stuff. But afterwards, he came to me to just get seen, and he never even brought in the lab results with him. And I asked him, I mean, like, did you get the blood work done and everything else, sir? I mean, he said, yeah, he got it through the private physician. He was told by the private physician the PSA is elevated, and there the discussion ended, actually. And then I went at length, I mean, about his lab results and all that. I asked him, I mean, actually to just do the name of his physician and all that. So we got the results back from his private physician. This actually even happened a few years ago while I was in Marion, Ohio. That's also one of the rural clinics where I worked by myself. I mean, like, there is no other physician. Basically, when we got all that information, I called back the patient. I asked him, I mean, like, what is his thoughts? And I mean, like, and basically I put a lot of emphasis on, I mean, like, just getting followed up. Either through his private physician, or I could just go ahead and put in the consult through the VA, through the urology. And he was actually seen quickly by the VA urology also. He got the biopsy done. When he got the results, actually he called me and he said, I mean, I thank you very much for Dr. Pavluri for taking a lot of time. And if you would not have intervened in between, I would have actually postponed all this. I mean, so that's my personal experience. That's why I'm more into that dual care thing. And a lot of times, actually, I mean, like, basically, sometimes, I mean, like, basically, even with the diabetes, new onset diabetes, a lot of patients, I mean, at least some of them, not a lot, I will say, they come in with the metformin and glyburide and all that, not even having the glucometers.
Wow.
Having the good diabetic education and glucometers. I mean, like, whenever I see them first time in my clinic, irrespective of whether he is given or not, I always check if he doesn't have a glucometer. The patient is walking out with the glucometer and with the education on that day. So that actually changed a lot. Actually, this morning, one of my patients actually, I mean, like, there is a significant improvement. This morning I saw one guy, I mean, like, his hemoglobin A1C is down from 8 point something to 5.8. He lost 30 pounds since the last visit, and I mean, there is a tremendous improvement. I mean, even in his cholesterol is way around 500, 1100 of triglycerides, and it all actually came down. And also, I mean, like, it's not the credit, I mean, that we need to take, I mean, like, and I really, I mean, like, congratulated him on his success, because it's his success. Eventually, he lost all those pounds and all that. I mean, so basically, I think, yeah, these are all the things. I don't know if anybody else has in the group has the similar kind of experience. That's the one, I mean, which motivated me regarding the dual care and all that.
Right, so kind of getting an understanding when, as you're saying in dual care, how he's going to one place and then going to another, and, you know, how can you work together to
Exactly.
become more effective in his care.
And what I'm planning to do is actually to create a separate template. I'm still in the process. I mean, like, right now, I mean, like, I got actually too much on my plate. I mean, so I'm just, my thinking is to create a separate template. Whatever is getting from the private physician, we're going to attach it. And whatever we're faxing it to them from our clinic, we're going to attach, I mean, like, a telephone clinic note, so that way, I mean, we can keep track of, I mean, like, what's coming in, what's going off, I mean, like, so that, I mean, we can still continue the continued care, I mean, like, without falling through the...
That's a great example, kind of, how do you deliver that information so that, you know, so the other physician on the other side is also kind of obligated to share his or her information with you as well. So it's a lovely example of how we can improve peer-to-peer information and improve that kind of transitioning not only between an inpatient or outpatient site, but between an outpatient site and another outpatient site.
And also, I think we have not only this, I mean, like, I think more problems with the narcotic things. Narcotic seek him here or something like that. I mean, like one is, I mean, yeah, improve the care, and the other one is, I mean, how to get it timely. Because, I mean, there is another one, I mean, like this morning I saw, the patient told me, I mean, like he never got any narcotics other than the VA. And then, I mean, like basically, and he was never even seen by any other hospitals. But when we contacted the local facility, he was seen twice. And one time, actually, he was actually arrested by, or I mean, taken by police to the local hospital because he was noticed intoxicated by the other people, and then basically fell down. The surrounding people, I mean, like witnessed him, and then basically immediately, I think the EMS team gave him some Narcan, and he came out of it quickly. So things like this, I mean, like basically, I mean, like if we're not really, I mean, like maybe we need a little bit more time, I mean, actually to even just go a little further and see basically what exactly is going on with the patient. I mean, like rather than, okay, sir, I mean, like, yeah. The only reason, I mean, actually I asked, I mean, is basically he went and to the main hospital and he said he wanted the narcotics, I mean, like a few days ago. And when he came to me for follow-up, I mean, like this morning, he said he never even asked for the narcotics. And things like that, I mean, like when you hear, I mean, some red flags and things like that, I mean, like maybe taking a little time, I mean, to explore the situation. Yeah, I mean, like if he's already, I mean, like taking, I mean, like, and I don't know where, because with the, unfortunately, with the VA directive, we cannot even run the CASPER reports or, I mean, like our inspector reports or anything like that. It's going to be really hard for the providers, I mean, like to see what exactly is going on.
Right, so it's like taking that extra step, as you're saying, and
exactly
being a detective in many situations, how, you know, we help minimize repeat testing or repeat consulting or, you know, unnecessary medications, side effects from other medications. So you're right in terms of, you know, that extra, can save you a lot at the end, taking that extra time at the beginning.
And I'm actually working on that, on the dual care model implementation, and I'm actually, I think I'm not going to present, I mean, in New Orleans, but this year, but I mean, actually, I'm still going to work on it. I mean, we're still trying to see what is the best way, how we can actually implement this, and I mean, then move forward. I mean, so maybe I'll take a little bit more time, I mean, and get everything done, and then maybe, I mean, like, just let you all know, so.
Great, thank you. Anyone else kind of want to share some examples of peer group that they've been part of? And they don't all have to be positive. We can learn from some negative experiences as well. So, any other examples, maybe?
Yeah, it's again me. I mean, like that's me. I have one more thing. I mean, like it's not actually. I mean, it's from the patient perspective regarding the travel issues. I mean, like when they're in the remote area, rural area. Basically, I mean, there was another case scenario also. I mean, like basically, patient he was never seen in the VA system. His sister called the day before. For the appointment because patient could not drink anything, and I mean it's hurting him, I mean even to drink and all that. So we gave him the appointment. Basically patient came back that day for his appointment. As soon as he opened, I mean we could easily see he has got definitely, I mean like more possibility for the oral cancer and all that. And then basically we discussed with the dental team. It's going. It's around 35 miles away from the rural CBAC, and I discussed with the dental team, surgeon, who are ready to take care of the patient. And after that, I mean, like basically, I came back and talked to him. He said he has his mother. I mean, initially he said he doesn't have anybody to take him down there, and afterwards he said, yeah, my mom is there. I mean, like down in the lobby, and I went and talked to her, and she agreed upon taking the patient. But when I came back to the patient, he said, "Doc, no, I have to pay from my pocket, for the gas, and basically I cannot go down there." I called the mom again, and asked her, it's not any disrespect or anything, but if I could provide, that money, it is very important for him to just go on that day, to just get seen by the dental team right away. And luckily, she agreed upon, and actually, I paid from my pocket, just for his expenses and all that. He went right away. The main reason is, basically because, he is thinking about the travel expense and all that, the cost of the journey is going to take from the rural to the main hospital. So that's regarding the veteran travel issues. I don't know if there is anything, that the VA can do, in that kind of setting. And because, this is a brand new patient to the VA, and and he was never seen.
Yes, these are really important issues, and I know, I think as we're wrapping up, Dr. Fernandez, maybe if any additional discussion is needed, maybe we can continue through email between the scholars and you, Dr. Fernandez, if that is okay.
Yes, that is okay. And I want you to really think about, kind of reflect upon, because I know that everybody's been somewhere down, somehow or somewhere down your career, have been part of a peer group. Maybe it's not a formally developed group, but you've checked in with a peer, you've talked to a peer, you've asked advice from a peer. Think about kind of what you've learned from that peer. What are some things that, were effective with that relationship? How did it help you? How can you be effective as a peer teacher in transferring knowledge? So how did it leave you with that thought that really the collaboration of our peers is what helps us really improve even much more in terms of, as I said before, in terms of promotions, in terms of creativity of projects, in terms of improving quality of care, in terms of having our own professional output as well. All of these are aspects that are really kind of these positive spins that we can put within our peer relationships. And it doesn't mean that it just has to happen with the person next door to us. It can happen over email. It can happen over a telephone conference. Somebody you met at a conference, that you still, that you should have reached out to, that maybe you had one conversation that was really exciting. How can you continue that relationship where maybe you see each other once a year at this meeting or twice a year at this meeting, but have a dialogue over email, over phone calls that really establish a more collaborative approach. And you can see, and you'll start seeing the benefits that are so inherent in having another peer that's going through the same things that you're going through and can understand your obstacles, your barriers.
Yes.
So I thank all of you for staying on with me, and look forward to speaking to you more in the future.
Yes, thank you, Dr. Fernandez. On behalf of all of the sponsoring organizations and also all of the geriatric scholars on the call, we want to thank you for taking the time today to speak with us. And this does conclude our webinar on peer-to-peer education. Just one last reminder to contact your VISN satellite coordinator to get the Scantron sheet to get credit. The second webinar will be April 19th, and the topic that day will be adult learning, and we'll send more details over email. Thank you all for joining us today. Goodbye, everyone.
Thank you. Thanks, Lauren.
I have just one question. Hello?
You had a question?
Yeah, do we have to call the vision coordinator to get the credit for this?
Yes, doctors who need to speak more about that with me, we can do that. So off the call, you are welcome to call me directly.
Oh, okay.
Okay, thank you all. Goodbye.
Bye.
Goodbye.